So I actually changed my practice based on a paper I'm going to tell you about today, and I think that you'll consider perhaps changing your practice to include mechanical bowel prep plus oral antibiotics plus perhaps intravenous antibiotics. I'm going to just and I feel as if I've been on a merry-go-round. Dr. Stamos said it earlier. We started one way, we ended up another way, and I think you'll conclude that we're back to where we started. And this is the paper that I think is going to get there. But what I thought we'd do is take a little journey together from the very beginning of bowel prep and antibiotics for elective colorectal surgery, and then we'll talk about a paper that came out in the Annals of Surgery in 2017. Sarah Kohler is a resident with us, and this is actually her thought, but it's a very powerful paper. Surgical site infection, I don't have to tell anyone in this room, is a major, major problem associated with every bad thing you can possibly think of: ICU admission, mortality, costs, length of stay, and readmissions. There are 160,000 surgical site admissions in the U.S. a year. 38% of all nosocomial infections are surgical site infections. 2 to 5% of all operated patients will have some type of infection, and that's of 30 million operations. So this is a major, major problem. Increases length of stay in the hospital, 7.5 days. It's about $13,000 per infection. And home health costs also. It's a major problem. It's defined, surgical site infection for this talk and by the government is defined as purulent secretion, organism cultured from the wound, or showing signs of infection, superficial or deep, organ or deep space, and within 30 days of surgery if you don't use an implant, or within 1 year of surgery if you do use an implant. So now we're all on the same page. We are tackling all these issues in colon and rectal surgery at the same time: the inoculum of the bacteria, the virulence of the bacteria, the microenvironment of surgical site. And most ERAS pathways try to address all of this at the same time: blood sugar control, oxygen, body temperature. But it's all to decrease this problem. So where did we start? It was 1964. And Bernard and Cole had 145 patients who were having surgery on the GI tract, and they used oral antibiotics, penicillin G, chloramphenicol, and methicillin, and they noted that their infection rate decreased from 27% to 8%. And that sat there for a few years, about 9 years, and then